Welcome back to our next section, which is dementia. Dementia, what is the fundamental difference between dementia and delirium? Now, dementia and delirium, the fundamental difference is that in delirium, you have a change in sensorium. Change in sensorium, what does that mean? Delirium means you're not awake, you're not alert, you are confused and have a loss of memory, but you're also not awake and alert. You're not aware of your surroundings. Dementia literally means I'm unmented. Dementia. I'm unmented. This means memory. Memories, like I cannot find my shoes. I don't know what I'm going to lose. Okay, memories only. Now, here in delirium, you are not awake, not alert. Dementia, I would make an excellent demented person. Like this. How you doing? Good to see you. How you doing? Engine undo. Hey. Apke say hey, dude. Namaste. Yeah. Hi, nice to see you again too. How are you doing? Hey, dobre utrak. Как вы поживаете? How are you doing? I can make an excellent demented person. I'm very friendly, very open, very alert all the time. Nobody notices that I can't remember your name and I don't remember whether I've actually ever met you before. Doesn't matter. I'm awake. I'm alert. Throw me the pen. Hey, thanks for that pen. What did I just do? Do what? Did you do something? Yeah, what did I just do with you? I don't know. Throw me the pen. Oh, okay. Yeah. What'd you just do? How you doing? Over and over and over again. Over and over and over again. Delirium is different. Delirium, ready? Delirium, you are having a calcium problem, you're having a sodium problem, an oxygen problem, you're having a glucose problem, you're having a uremic problem. Delirium, you're having a toxin problem. All these things, you ready? Delirium. Dementia, how you doing? I can't even remember your name, but I'm doing great. Hi. Now, I want you to notice about delirium. Does that list of things look familiar to you? Does that look familiar to you? The things that cause delirium, when they become really, really, really bad, develop into seizure. A seizure. When it becomes delirium and it gets really bad, causes me to convulse and makes me very sad. Delirium ultimately causes a seizure when these things become much worse. Now, dementia, ready? A loss of memory, okay, to the point, though, of, you see this word here in this slide? It says to the point where it interferes with social or occupational functioning. Interferes. You see, you can remember, forget small things. You can fail to remember small things. But when you get to the point that in your social interactions, you are repeating what you say over and over with the people you love in your life, that they want to strangle you and kill you, then it interferes with social functioning. So you see, there's not a problem with some occasional memory loss, but it's the fact that you're always saying the same thing over and over and over again, to the point where they say, are you going to keep repeating yourself, or can I talk now? So that's what it is. So a little memory loss is not a problem, but repetitive to the point of social impairment, that is a problem. That is a problem. Our next thing here, oh my God, look at all these causes of dementia. Okay, oh my God, look at all these things. Hypothyroid, B12, uremia, vasculitis. Oh, this is too much information. Too much information going through my brain. Too much information driving me insane. This is too much here. Well, how we're going to look at this is this. How far do you have to go in a dementia evaluation for the routine patient? I've been doing dementia evaluations for a long time, looking for thyroid problems. Guess how many people come across with hypothyroidism? A geriatrician in 35 years finds one single person in 35 years doing all these thyroid function tests, hypothyroid, looking for dementia. Almost never happens. Neurosyphilis with the RPR or a VDRL. Neurosyphilis, an RPR, VDRL, well, neurosyphilis happens to be at the lowest reported incidence in the history of the United States. Primary syphilis took a little bump in only 2 places in the United States, the Lower West Side of Manhattan and San Francisco. Other than that, 80% of counties, if you break it out county by county in the United States, 80% of counties in the United States actually had 0 cases of syphilis last year. Syphilis is one of the most economically and socially loculated diseases in the country. If you make above $30,000 a year, and don't live in the rural American Southeast? Say, sister, what are you doing tonight? Well, brother, I don't know. What are you doing? Well, it is one of the most socially and economically loculated diseases in the country. As a matter of fact, if you show me a country that has a per capita income above $8,000 a year, I will show you a country that has no malaria, no acute rheumatic fever, no tuberculosis, and no syphilis. No typhoid. If you show me a country that has above $8,000 a year per capita income, you have just cured malaria, you've just cured syphilis, you have just cured tuberculosis, you've cured acute rheumatic fever. Done, done, done. Somewhere between $6,000 and $8,000 a year, along the way, all those diseases become eradicated. Okay? Neurosyphilis, extremely rare. How far do you have to go in the evaluation of dementia? Well, we should do a CT. Well, why are we doing a CT? Well, stroke. What's the second most common cause of dementia in the United States? What's the most common cause? Alzheimer's. Second most common, multi-infarct dementia. Normal pressure hydrocephalus on a CT. Oh, normal pressure hydrocephalus. Why, I'm wobbly. Gait ataxia. I'm wacky. Dementia. And I'm wet. Incontinencia. Wobbly, wacky, and wet for normal pressure hydrocephalus. Gait ataxia, wide-based ataxic gait, PP, and demented. Normal pressure hydrocephalus. Tumors can do it. Now, here's the other thing in terms of these causes of dementia. B12 disease. What is the most common neurological abnormality of B12 deficiency? What is the most common neurological abnormality of B12 deficiency? The most common neurological abnormality of B12 deficiency is, oh, I see you thinking. Come on, come closer. Come closer. I see you out there. You've got a headset on and you're leaning forward. Come on, come closer. I know you hate it when I say that, but I want you to do it anyway. Okay, come closer. Come here, kiss the screen. Okay. What's the most common neurological abnormality in B12 deficiency? Is peripheral neuropathy. Peripheral neuropathy. What is the least common manifestation of B12 deficiency? Dementia. 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 Okay? Progressive multifocal leukoencephalopathy. Progressive multifocal leukoencephalopathy. You're going to look for it in someone who's got AIDS, low T cells, AIDS, low T cells, AIDS, low T cells. You diagnose it on an MRI. AIDS, low T cells, you diagnose it on an MRI. It's a special virus called the papovavirus, the JC virus. What's the JC virus stand for? No, it's not Jesus Christ. No, it's not Jakob Creutzfeldt. I heard you out there. You thought Jakob Creutzfeldt. First of all, it's not Jakob Creutzfeldt as a disease. It's Creutzfeldt-Jakob. Yeah, Creutzfeldt, he was here first. Yeah, Creutzfeldt and Jakob. Yes. Creutzfeldt and Jakob, CJD, is not the JC virus. JC is actually the initials of the first patient it was described in at New York Hospital here. Okay? Cornell University. Just the initials. BK virus, another one. Initials of the patient. JC virus, BK virus, they're just initials of patients. What an unimaginative crowd, right? Okay? What an unimaginative crowd. So the thing is, the JC virus gets better by fixing the antiretrovirals. Fix the antiretrovirals, you'll fix the HIV. You fix the HIV, the PML goes away. Let's do something trendy. Let's do something trendy. Something trendy now is Lewy body. Lewy body dementia. Lewy bodies. Lewy body dementia. Well, I guess it presents with loss of memory. What's different about Lewy body? What's different? What's different about Lewy body dementia from all the others? Lewy body dementia presents with symptoms of Parkinsonism. It presents with Parkinsonian syndromes. Parkinsonian symptoms. Parkinsonian symptoms. It presents with hallucinations. By the way, what's the difference between a hallucination and a delusion? What's the difference between a hallucination and a delusion? Hallucination is a sensory or auditory, visual or auditory, something you see. It's a perception, something you see or hear, something you see or hear that's not there. It's something you hear or see that's not there. What's the difference between that and a delusion? That's something that you believe that's not there. If I see Jesus Christ in the room, that's a hallucination. If I believe that I am Jesus Christ, then that's a delusion. So if I see Jesus, that's a hallucination. If I believe I am the Messiah, that's a delusion. Is that a delusion? Yes, that's a delusion. That's a fixed false belief. It's a fixed false belief. So you get hallucinations and Parkinsonism, Lewy body dementia. That's a very trendy one, Lewy body dementia. Well, what's the difference between that and Pick's disease? Pick's disease, also known as temporal or frontotemporal or lobar atrophy. Lobar atrophy, what lobe? This lobe? No, the lobes of the brain. Lobar atrophy. What's different about lobar atrophy from Alzheimer's? Lobar atrophy. Pick's disease. Pick's disease is a little like me. Social appropriateness goes first, and memory stays intact. So social appropriateness is the first thing to be lost. First you lose your social appropriateness, then you lose your memory. First you lose your social appropriateness, then you lose your memory. Pick's disease. Oh, back to Jakob Creutzfeldt. Ja, Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease. What's going to be different about Creutzfeldt and Jakob? Yeah, You can't say. So have you had any transplants of dura mater from someone else? Have you had unprotected contact with anonymous stereotactic needle biopsy needles? Had any pooled growth hormone product? What's different about Creutzfeldt-Jakob from the others? It's got to have a unique presentation. You know, the difference between life and the boards is on the boards, if they want you to know the answer, they have to tell you something. If they want you to know the answer, they have to let you know. It's not like life. What'd you get me? An espresso. Why'd you get me an espresso? I want a cappuccino. Well, you said espresso. Yeah, but you were supposed to know I meant cappuccino. Well, if they want you to know the answer, they have to tell you. What is there going to be different about Creutzfeldt from everybody else? From Alzheimer's, for instance. Creutzfeldt-Jakob is very rapid. From diagnosis to death in less than 6 months. From diagnosis to death in less than 6 months. Rapidly progressive dementia. What else? Myoclonus. 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 Myoclonic jerks. Myoclonic jerks. What's different about Creutzfeldt-Jakob? I got a myoclonus. Guy's got great rhythm. It's as close as I get to good rhythm. Myoclonic jerks. Myoclonic jerks. Rapidly progressive dementia with myoclonic jerks. Rapidly progressive dementia with myoclonic jerks. Creutzfeldt-Jakob or Creutzfeldt-Jakob disease, yeah. What's the most accurate test? Is a biopsy. Most accurate test for Creutzfeldt-Jakob disease is a biopsy. However, cerebral spinal fluid can be done to eliminate the brain biopsy. I have rapidly progressive dementia with myoclonic jerks. Biopsy is the most accurate test. The therapy is D5 inshallah. D5 Ganga water, D5 holy water. There is no therapy. Rapidly progressive dementia with myoclonic jerks. Head CT, brain biopsy, no therapy. But, you know, I don't want to do a brain biopsy. Do you want to do a brain biopsy? Man, I don't know. But, you know, you want to take care of people. You know what I mean? You're trying to show some love. And you've got to do a brain biopsy, trying to show some love. And, you know, love hurts sometimes. So, but I need a brain biopsy like I need a hole in my head. So, all right, I give that a 2. All right, so the thing is this. What can we do to avoid? What can we do to avoid the pain in our relationship? What can we do to avoid the penetrating trauma of the hole in our head? Why can't we all just get along? So what test can we do that allows us to diagnose Creutzfeldt-Jakob disease without the benefit of brain biopsy? I should say not the benefit, but the pain of brain biopsy. There's another test on the cerebrospinal fluid. It is called the level of 14-3-3 protein. 14-3-3 protein. Now I can see that you are having a virtual exultative moment of being delighted to have a fact like 14-3-3 protein to memorize. Except it's a great thing. You see, whatever Creutzfeldt-Jakob disease is, it sheds this protein into the CSF. It sheds this protein into the CSF, and when you look at a person with rapidly progressive dementia, myoclonic jerks, and the CT shows nothing, this does spare people the need for a biopsy. The other thing is, there's no treatment for Creutzfeldt-Jakob. You're going to die. How do new diseases get described? Well, they're not more intelligent than you. They're more persistent. The fool who persists in his folly becomes wise. Persistence. So the whole point is that you have a person who might have Creutzfeldt-Jakob and they're going to die. But how do you know that the person you have has Creutzfeldt-Jakob? 14-3-3 protein. Oh, but the attending says we don't want to do the brain biopsy. It's probably Creutzfeldt-Jakob. Just pull a sheet over his head. Well, how do you know that it's not a disease that's never been described? How do you know it's not Babu syndrome? Could be Babu syndrome, okay? You don't know. Maybe it's a disease that's never been described before. You don't know. Could be. It could be. So therefore, 14-3-3 protein allows you to diagnose the Creutzfeldt-Jakob. Maybe it's not Creutzfeldt-Jakob and it's a curable disease that has never been described. Oh, some people look at the world as it is and say, why? I dream of things that have never been and say, why not? Robert Kennedy. Robert Kennedy. So therefore, 14-3-3 protein becomes a great thing for all the people that would say, brain biopsy is too difficult. I don't want to do a brain biopsy. How many brain biopsies have you seen this year? How many brain biopsies? How many brain biopsies did you see? Oh no, too difficult, too much of a pain in the ass. We just let them die. Well, I don't think the dead will mind having had the 14-3-3 protein. And if it's negative, do the brain biopsy. If it's negative, then do the brain biopsy. So what we've done here is we've given you something different and what's unique. How far do you have to go in the evaluation of routine dementia? Thyroid, RPR, CT. You do not have to do the lumbar puncture. When it says 78-year-old man is coming to your office for evaluation of progressive memory loss. He's brought in by his wife, who progressively says that he can't find the things that he has misplaced. You have a normal head CT that has been done. Thyroid function tests are normal. Head CT and thyroid function tests have been normal. Which of the following is the most appropriate to do in this patient? A, 14-3-3 protein. B, brain biopsy. C, CSF. D, B12 deficiency. E, VDRL. Well, VDRL is how far you have to go. You do not have to do a lumbar puncture and cerebrospinal fluid for dementia. If you look at this here, except for Creutzfeldt-Jakob, none of these are diagnosed on CSF. And people don't show up with meningitis and encephalitis, giving them 6 months of memory loss. Encephalitis is acute febrile dementia. Delirium, excuse me, acute febrile confusion. Acute febrile confusion. Acute febrile confusion. Throw a fever into this, and that is encephalitis. Acute febrile confusion. Then you say herpes PCR, herpes PCR, herpes PCR acyclovir. Acute febrile confusion, herpes PCR acyclovir. You do not have to do the CSF in the routine evaluation of dementia. CSF is incorrect. You do not have to do a brain biopsy in the routine evaluation. You do not have to do 14-3-3 protein unless you see rapidly progressive dementia in myoclonic jerks. Why is this important? Because you don't know which of them there is. You don't know. Maybe it's an undescribed disease. Let's look at what we got here. Oh my goodness, look at this. This looks like Jackson Pollock. You see this painting here? Is this a Jackson Pollock? Look at the splatters. Look at the thing. Is he a genius or just an alcoholic? I mean, it's hard to be able to say. Look at this. It looks like a splatter painting. Get this up in the Museum of Modern Art. It is neurofibrillary tangles. Amyloid plaques and neurofibrillary tangles. The interesting thing is here is that I could be pointing to anything here and you wouldn't know which one it was. Amyloid plaques and neurofibrillary tangles. Okay, dementia. Let's see. Mild cognitive impairment means just a little memory loss, but not to the point of impairing social function. Alzheimer's disease is you exclude all of these. You lose memory enough to have impairment of cognitive function and social function. However, you've excluded all the other things. You've excluded all the other things. Lewy body means fluctuating cognitive impairment, but remember, Lewy body also means Parkinsonism and hallucinations. That's when it says fluctuating cognitive impairment. That means that you're also getting hallucinations. You're also getting hallucinations, okay? Parkinson's is a cause of dementia, but at the very, very, very end. Parkinson's presents with the shuffling gait and hypomimia and inability to move, and only after 20 years of Parkinson's disease do you get dementia. That's a very unusual cause of dementia. Next slide, we see our Creutzfeldt-Jakob. Rapidly progressive dementia with myoclonic jerks. Multi-infarct dementia means that you have a stroke and you get worse. You get a little better and you get worse. The stroke is a little bit like that relapsing, remitting multiple sclerosis. Multi-infarct dementia. Did you know that out of every 100 people who have a stroke, what percentage of them develop dementia? Let's do it this way. If your mother or father has a stroke, what's the chance they're going to become demented from one stroke? You know what a stroke is for the brain? It's like a myocardial infarction from the heart. You know what dementia is? Left ventricular systolic dysfunction for the brain. Decreased output. If you have a myocardial infarction, you can get congestive failure, systolic dysfunction, low ejection fraction. If you have a stroke, you have a decreased output, dementia. Did you know that for every 100 people who have a stroke, 25 with a single stroke? If you have a stroke, you got a 1 in 4 chance of having dementia. Well, that sucks. Man, I'd hate to do that. Dr. Fisher, did you have a stroke? Yeah. It took out nephrology and the endocrine section of my brain. Damn. Ooh, what would I do? I mean, I'm basically a professional learner. I'm a professional memory creator, hope salesman. What would I do? Well, I'd be intercourse, that's what I'd be. So the whole point is, 25% chance that you are going to have dementia with 1 stroke. I know you're getting upset because I keep saying you instead of the patients. You are the patient. Me too. Stepwise progression. 1 stroke, 25% chance. Next slide. Next slide is the diagnosis of dementia. The diagnosis of dementia basically comes down to this. Can you remember 3 objects at 5 minutes? Can you remember 3 objects? Okay. What is the date? What is the day? Who is the president? Can you remember 3 objects at 5 minutes? That's the mini mental status. Can you count backwards from 100 minus 7? Can you count backwards from 100 minus 3? Can you spell world backward? How do you spell world? Can you spell world backwards? Calculations, memory, orientation. Spelling world backwards and see whether somebody can handle that. How far do you have to go in the routine evaluation of dementia? This is as far as you have to go. This is as far as you have to go in the routine evaluation of dementia. CT, thyroid, RPR, B12. CT, thyroid, RPR, B12. That's as far as you have to go. Now let's look at our atrophy here and cerebral atrophy, Alzheimer's disease. This is your corpus callosum. Corpus callosum here. Here's your cerebellum. Here's our 4th ventricle. This is the, looks like a prostate, but it's not. It's the pons. Okay, here pons, cerebellum, 4th ventricle, corpus callosum. Diffuse symmetrical atrophy. You notice how in this picture the ventricles are very, very, very big. The ventricles are big. But if you look here around the edge, you will see that the brain is rushing out to fill the calvarium. The brain is rushing out to fill the calvarium. The brain is rushing out to fill the brain is rushing out to fill the calvarium, and that's so that as your brain, the brain atrophies, as the brain atrophies, instead of the brain atrophying and being inside of a skull like this, then every time you do this, you go, let me think about that. Ka-tonk. On the other hand, the brain would go ka-tonk. So the brain has to float out to fill the calvarium, the inner table of the skull, so that it won't bounce around. And you see this piece here? That's called the Sylvian fissure. The Sylvian fissure. And the Sylvian fissure, Sylvian, where we get the word sylvatic, the ancient Greek, blissful, peaceful, pastoral setting Sylvian, is hugely enlarged. Next slide. Alzheimer's disease. Alzheimer's disease, let's look at the treatments. We think that if you increase acetylcholine, you will get better memory. So we can use donepezil, okay, which is Aricept, rivastigmine, which is rivastigmine, okay. Tacrin used to be on, but Tacrin caused liver function test abnormalities. Tacrin caused liver function test abnormalities, so Tacrin is no more. Tacrin is gone. Tacrin is historical. Tacrin is archaeological, dead, finished. Rivastigmine, donepezil, rivastigmine, or galantamine. Galantamine. These all increase acetylcholine. They do not have any objective difference between them. I want to increase acetylcholine in my bladder. I give bethanechol. It goes to the bladder. I got a big floppy bladder. I want to give acetylcholine. Bethanechol. Acetylcholine for the bladder. It makes it constrict. Acetylcholine in the lungs makes the bronchi constrict and secrete. Constrict and secrete. Acetylcholine in my bladder. Constrict and secrete. Acetylcholine in my guts. Constrict and secrete. Constrict and excrete. Constrict and excrete. Acetylcholine, salivation. Acetylcholine, lacrimation. Acetylcholine, urination. Acetylcholine, defecation. Acetylcholine, salivation, lacrimation, urination, defecation. Salivation, lacrimation, urination, defecation. Well, acetylcholine will also make your brain increase its output. What's the secretion of your brain? Beauty. What's the secretion of your brain? Thought, goodness, truth, beauty. Thought, love. What's the secretion of your brain? In your guts, it's stool. And in your brain, it's love. So basically, this is a positive inotrope for your brain. This is cerebral digoxin. Increases the ejection fraction of the output of the brain. A poet is someone who pours light into a spoon so he could bring it and pour it into your beautiful, holy, parched mouth. Rivastigmine and all these others, acetylcholine, increases your excretion of your brain. Now, there's one other drug in that class, memantine. Memantine, I like the name because it's a lot like memory. Memantine protects the neurons of the brain. And that's one simple function of memantine. Alzheimer's disease is dementia. You could narrow Alzheimer's disease down to this. Memory loss to the point of screwing up your life, all the tests are negative, and your brain is atrophic. Give them one of these drugs, and that's Alzheimer's. What else do we say in the dementia section? Lewy body is trendy. Lewy body is trendy. Hallucinations and Parkinsonism. Pick's disease. Pick's disease. Picks out your emotional flow. Picks out your social function. Picks out emotional function. Picks out social function. Leaves your memory intact for a while. Creutzfeldt-Jakob mania. Rapidly progressive dementia with myoclonic jerks. CTLP 1433 protein can eliminate the need for biopsy. Normal pressure hydrocephalus. Wobbly, wacky, wet, incontinence, wide-based gait, dementia. Multi-infarct, the number 2 cause of dementia. Why? Because for every 100 people who have a stroke, 25% of them become demented. Wow, that sucks. That sucks.